Ladies and gentlemen, very good evening to you all, and welcome to this Bracco UK webinar on stress echo. Before getting started, I'd like to thank all of you for joining tonight's meeting and to thank the BSE for endorsing the course and allocating 1 point credit. I must inform you that the webinar will be recorded and that it will be made available online in the upcoming weeks. Your questions are, of course, welcome. Please ask them by using the Q&A button at the bottom of your screen. You can ask them during the lecture if this is a burning question, or at the end, because there will be a dedicated QA session. I will introduce our moderator, Renate Hampson. She is a senior chief cardiac physiologist with more than 15 years experience in contrast echocardiography. Currently, she is a research and education physiologist lead in the cardiac research department at Northwick Park Hospital. As part of the research team, Renate has been involved in numerous single and multi-center studies designed to evaluate ultrasound contrast agents, including developing the clinical application thereof in echocardiography, stress echocardiography, and myocardial perfusion. Renate is a fellow of the BSE and a member of the Stress Echo Accreditation Committee. She is a passionate advocate for physiologist-led services, and she is a keen educator wanting to share her knowledge and experience to help encourage sonographers and develop services. Renate, the floor is yours.
Jerome, thank you so much for that lovely introduction. It sounds so much better coming out of your mouth. Thank you for bringing us all together this evening, and I'm delighted to be moderating this evening's event, and thank you very much for inviting me. And I'm happy to introduce our first speaker, Professor Martin Stout, who looks like he's recovered after a very BSE conference this weekend. Yes. Martin specializes in cardiac imaging at Wythenshawe Hospital in Manchester. He's immediate past vice president of the BSE and has been a council member and a trustee for many years. He's an honorary fellow of the BSE, fellow of the EAC, and also an honorary professor at Manchester Metropolitan University. Tonight, Martin is going to give us an update on stress echo accreditation process. Thanks, Martin.
Thank you very much, Renate. Hello, everybody, and welcome. I'm just going to share my screen, so hopefully this will work. It has worked before, so let's hope it works again. Hopefully you can just read all my emails, but I'll open the presentation. Can someone please give me a nod to say they can see that? Yes, thumbs up. Okay, perfect. So I've been given the task of running through the BSE stress echo accreditation process based on some new publications that's come out this last year, replacing the old one, which was probably some 7 or 8 years old. So the obvious thing, and my obvious bit of advice to everybody, if you're thinking about undertaking stress accreditation, is please read the pack. Don't just read it once, read it thoroughly and read it properly, because literally every single bit of information you will ever need to know is in that pack. And if it's not in there, there's lots of contact information for people within the BSE who'll be able to help you out with that. So what I thought I'd cover was the aims of the accreditation process. So why is it we actually want to do it? What requirements you need to actually get into the process itself and undertake the process, because it's not as straightforward as just applying. You need some background to get in to do the process. And then we're going to talk a little bit about the process itself. So the theory aspects of the process, that includes the MCQs, the multiple choice questions that are as part of the theory process, the questions related to the video cases as part of the process, and then the practical element of the process. And the practical element currently has 3 parts to it. So there's a logbook of cases that need to be collected. There's a practical scanning assessment where you will scan a volunteer, and then a Viva assessment on your own 5 video cases that you put together yourself. And then I'll bring it all together with a quick summary at the end. So what are the aims of the process and why should we actually do it? So, I mean, this process is run for the members of the BSE. So the first sort of point to note is that if you are not a member of the British Society of Echocardiography, then you can't undertake the process. You have to be a member to undertake the process. And it's run as a service for the members. It's not compulsory. There are lots of people around the UK performing stress echo and performing stress echo to a very, very high and very good standard who don't have the stress accreditation. But it's there as a process to help our members ensure that they are providing good quality and good quality for the safety of our patients. And certainly within the BSE, that's the main thing that we want to look after. We want to look after our members to make sure they feel competent. And in that way, we'll look after our patients to make sure they feel safe. By achieving the accreditation, then we expect that the individual will be able to perform and report their own stress echo studies unsupervised. Okay, they are there to lead the study. It's them leading the room. It's them leading the study and undertaking the analysis of the images or whatever it is that needs analysis. It's up to them and it's down to them. That doesn't mean to say that you can't ask for help. And I underwent this process, God knows how many years ago, 2016, 2017. I still ask for help now because it's important to have that MDT and have people around you and ask for help at times. We've already gone through this, but it's two parts. There's a written theory examination and a practical assessment, and you have to basically pass both to become accredited. And it's a minimum requirement, and it's not a guarantee of competence. It doesn't necessarily mean that you're going to be the best in the world at stress echocardiography. It's the minimum sort of standard, and you should still undertake your own learning. You should still undertake your own work at conferences and update your knowledge because you have to reaccredit. And that's why the BSE like to put in the reaccreditation clause. So after 5 years, we expect you to have been maintaining your practice, improving your knowledge so that you can prove that you are maintaining your standard, at which point you can apply for reaccreditation. And the reaccreditation part falls probably slightly outside this presentation, but there's details of the reaccreditation processes on the BSE website itself. There's further requirements that you need to think about. So it's not just being a member of the BSE. You have to have a level 2 accreditation in transthoracic echocardiography with the BSE. So you can't get yourself into the stress accreditation process unless you're a member and you've got the level 2 standard in adult transthoracic from the BSE or an equivalent. And the equivalent that we currently would look at is the AACVI accreditation. You need to have a designated mentor, and I'll talk about mentors a little bit later, but the mentor is very important, and the choice of mentor is particularly important. I'll mention that a bit later on. Both of the elements need to be passed. You can't progress onto the practical side of the assessment unless you have passed the theory side of the assessment. We're going to go on in a little bit to look at the different aspects of the assessment. So the theory assessment being the multiple choice questions, the MCQs, and what is termed a best answer image reporting section. And then we'll talk a little bit later about the logbook, the practical scanning assessment itself, and the 5 case studies that you have to put together as a Viva. You also need to be aware that there's a time limit to this process. And this is actually slightly wrong. So the original documentation says that you have a period of no more than 24 months from passing the written examination to complete it, but it's actually been increased to 26 months to give a couple of extra months grace to get the logbook together, make sure the Viva cases are put together properly. It gives you that little bit extra leeway. So that's actually been increased to 26 months now. So for the theory assessment, there's lots of stuff in the accreditation pack to help you, although you're going to need to do some of your own research and find some of your own reading to support what's in the accreditation pack. So the pack itself in the appendix contains the full training syllabus. So all the theoretical aspects you need to know is in the appendix, and all the practical competencies that we expect that you will be able to achieve under the supervision of your mentor will be in the accreditation pack as well. And there's also a recommended reading list. And the recommended reading list is not only to help you with the theoretical aspects, it's also there to help you with the practical aspects of performing stress echo as well. We tend to only hold a theory assessment once a year, and it's usually in the autumn time. And we hold them with one of our companies that we use called Pearson's View, who basically have centres across the UK, Republic of Ireland. They even have some overseas locations. And for those of you young enough, not me, to have undergone your theory driving assessment, it's very much similar to that, where you would go get your own computer in your little cubicle, and under exam conditions, you will work through the theoretical aspects. BSE are very good on social media, very good at announcing dates. The website tends to be updated very regularly. So all the dates and venues and times of all these things are very, very sort of well recognised. So the theoretical part itself, it's got two particular sections. There's an MCQ theory section, and then there's a section on image reporting, and you have to pass both parts of those to actually pass the theoretical aspect of the assessment. For the MCQs, you need to get 70%. And in a little while, I'll tell you exactly how it's formatted, but basically that means getting a score of around 70 out of 100 on the on that section. And you need to pass the imaging section, you need to get 60%. Not very often, but occasionally, if it's found that the exam is exceptionally easy, which tends not to be exceptionally easy, or exceptionally hard, then the accreditation committee might moderate it and adjust the marks a little bit based on whether everybody was getting really high marks or everybody was getting really low marks. You can sit the theory as many times as you like, but you only get accredited once you've passed the practical assessment. So you can't say you've passed the theory part and you're partially accredited. We don't offer that sort of accreditation. It has to be the whole thing or nothing. So the MCQs, here's some examples of the questions, and these are just lifted straight from the accreditation pack itself. Basically, there are 20 questions, and for each of those 20 questions, there are 5 stems, and you need to answer every one of the stems for each one of the question. And it's always a true or false type answer to the statement. There's no patterns or any tricks or anything like that. You could have 5 trues, 5 falses. You could have a mix of true and falses. There's no tricks or hidden things to it. And basically, you get my computer's decided to update. You get a mark for a correct answer. If you get it wrong, you get a 0. And it's not like it used to be when I first did my transthoracic accreditation many years ago. If you got the wrong answer, they don't knock a mark off. You just don't get a mark, full stop. So your maximum number of marks based on 20 with 5 stems is 100 marks, okay? And you need 70% of that to actually pass that particular section. The image reporting section is split into around 15 cases. And for each of the 15 cases, you will receive a bit of a background on the patient. This is just an example I've put together. The background you get obviously will be different dependent on the pathology of the patient. So there might be a bit more of a background if it's, for instance, a structural type case. For a fairly straightforward ischemia case like this one, it might be quite a short background. You'll get some data that's been taken throughout the test, the blood pressure and other things. And there will be, for each of the 15 cases, a stem of answers, and you need to choose a single best answer that represents that case. So in this example here, the single best answer of true is evidence of ischemia, likely in the LAD territory. You actually get 90 minutes for this section because obviously it's a little bit more intensive. And your maximum, obviously, your maximum possible mark for that based on 15 cases and 1 single best answer for each is 15 marks. And you need 60% to pass this section. So the practical assessment, we try and run that twice a year, and that's based on the demand of the number of candidates. Sometimes we don't get to run it twice a year. We have a limited pool of assessors, and Renette will testify to this. And because of that, it's based on our time demand as well. So it's probably not practical for us to run 4 or 5 every year. So we try to run up to 2 every year. Again, the BSE are very good at publishing where and when, and they will have a waiting list of people, and they will prioritise the ones who've been waiting the longest. The practical assessment, so 3 parts, like I mentioned. You need a logbook, and that has to comprise of 200 cases. You will undergo a practical scanning assessment on a normal volunteer, and then you have to present a number out of 5 case studies. We don't often ask you to present the whole lot. It might be 3 out of the 5, and we will decide beforehand which cases we were going to get everybody to present. And then obviously, if we're not happy with some of the answers, then we quite often ask them to go through the others, just so we can ensure that they are competent and we can ask enough questions to make sure we're satisfied. So as I said before, you need to attend this within 26 months, starting the process. So we give that extra 2 months grace, but you can't register for it. You can't register for the practical until you have successfully passed the theory. So you can't edge your bets and fancy your chances that you've passed and register before you've actually completed the theory aspect. And it sounds really common sense and straightforward about the candidate's responsibility to put correct information on stuff, but there's lots of times where people don't fill in things properly, and then they get really cross that they've not been added to a list, or they've not appeared on a list that they think they're going to appear on, and that's simply because a lot of the time they've not filled in things properly. So it's really important to make sure you get all the paperwork done correctly. So the logbook itself, so 200 cases, there needs to be a case mix, and this is important. So the case mix, there needs to be at least 40 that demonstrate ischemia or viability. And that's a minimum number because we know that that probably makes up the bulk of a lot of the department's work. At least 20 of the cases should demonstrate structural heart disease. And by that, it's usually going to be moderate to severe valve lesions or cardiomyopathies, hypertrophic cardiomyopathy, dilated cardiomyopathy. And the candidates should be able to justify that they've used the right test on the right patient at the right time, and they will be questioned on that. At least 50 of the cases, which is, I should say, all the cases, but I can't say that, I'm sorry, but at least 50 of the cases should use transpulmonary contrast. And we expect that people are able to use it and understand how to use it properly. We generally find that it's a lot more than 50 cases that have been used with transpulmonary contrast. And a high number, a maximum of 140, can actually be normal. Okay, and that's based on the fact that 20 structural are definitely abnormal. You only need to find 40 ischemia, so the rest of the 200, the main bulk, can actually be normal. There are some caveats to that. At least 25 studies need to demonstrate that you can use another modality. So you can't just use dobutamine stress for the whole lot. You have to be able to use exercise, and whether that be a supine bicycle or a treadmill. And at least the last 180 of the 200 cases need to have been reported by the candidate itself and signed off by the candidate. And you're allowed to have a small number of 20 that have been overseen by a supervisor or a mentor. The rest of the ones have to be done by the candidate themselves. The logbook portal's online. There's a link to that. So that makes it easier nowadays. You don't have to turn up with a big folder full of cases. You can upload your reports online, and that's really important. And it makes anonymizing them a lot easier. This is the marking criteria we use. So when you come to the practical assessment, we will look at a number of the cases in the logbook, probably before you actually come, prior to you coming to the assessment. And we will look at these different criteria here, and we will just check that the reports make sense, the reports contain adequate information, and everything looks like the candidate is fully competent in performing stress echocardiography. Scanning assessment itself, performed very much in a room like the one on the photograph. That's a typical setup we have on a day. We always perform exercise stress as a practical element, and we always use a normal volunteer that we've looked at before so we can see if they've actually got good pictures. Now, obviously, because it's a normal volunteer, we generally don't give contrast to these volunteers because of the small but not insignificant risk of reaction. But we know they've got good pictures because we've checked and we've had a look. So when you come to scan these volunteers, we can tell pretty much straight away whether you've been competent with a probe in your hand, and you can get the required images. You can actually choose whether you do the bicycle or the treadmill, whatever it is that you actually prefer. You just need to tell us before you come on the day. But you're only allowed to use protocols that the BSE recommend. So for the bicycle, the WHO 25-watt protocol, or a Bruce protocol for the treadmill. We have a glamorous assistant usually in the room who can help work the equipment. So they will do blood pressures for you if you want blood pressures. They will increase the load on the bike. They will work the treadmill, the Bruce protocol. So you don't have to think about any of that, but you have to direct them. You have to be able to come into the room and lead the room as you would with a clinical patient. We don't expect that everyone will be able to work the machines. This is a GE machine in this example. If you're using Philips or Siemens and that's your main equipment, we don't expect that you'll be able to come in and understand how to adjust every single item on the machine. All you need to do is ask, and the assessor in the room will guide you through that, or will do it for you. What the assessor won't do is take the probe off you and get the pictures, and that's the most important part. And it's very clear to us when we're in the room who's competent just by watching them practically scan, and how they run the room, and how they run the room as if there's a clinical patient in the room. We don't often complete a full study. Once we're happy that the images are suitable and the candidate knows pretty much what they're doing, we might terminate the test before we reach peak heart rates. Again, there's marking criteria for this. We generally have fail, borderline fail, fail, borderline pass, and pass, and we give them a weight. So we classify certain things as more important than other things. We don't try and trick people. We're not trying to make people fail, but we will ask questions. We want to make sure you're competent. So we might ask you questions about the pathology. We might ask you questions about what you might do if there's a contrast reaction. We might ask you questions as to when you might stop the test if there's lots of ischemia or other things. The best piece of advice is treat it as if it's a clinical situation, and it's very artificial and it's not a clinical situation, but you should walk into that room as though you're walking into a room with the patient in, and you ask the same questions and you go through all the safety elements and you perform the test as you would with the patient. The scenario is pretty much always the same. It's always going to be an ischemia patient, but the volunteer who you will be scanning will be given the scenario, and they will be prompted on what questions they probably should be asked and how to answer them. And they will answer them as though they are a patient, and that will help you interact as you would in a clinical environment. Coming to the end now. So for the Viva case presentation, we expect you to put together 5 cases, a normal dobutamine study, a normal exercise study, that could be a bike or a treadmill, a reversible ischemic response, and that could be a dobutamine or an exercise study, a non-viable or viable myocardium, and a structural heart disease case. For each of those, we expect that you will put them together and you will acquire the correct views for the correct pathology, and you will use the correct protocols for the correct pathology, because we're going to look at those in quite a lot of detail. And here's an example of the marking criteria just for the normal dobutamine stress echo. We look at quite a lot of detail and we will ask lots of questions. And my main bit of advice for this is put it together like you're going to present a case at a conference on a PowerPoint. Give a full background, give a full history of the patient, put together your rationale, get your images in there, get your report in there. And really importantly, please check your images play. The amount of times that people will come to be assessed and they go to show the images and they don't actually play. So my own advice is bring your own laptop where you know that the images play on your own laptop. Again, be prepared to explain your rationale, be prepared to be asked questions. And these should be your best possible cases. They should be really crystal clear. And another really good bit of advice is be obvious. Yeah, put in really clear images with really barn door pathology, and that will limit the amount of questions like myself and Renette could potentially ask you, because it becomes very obvious that it is what it is. I'm not saying don't put in anything that's really complex, but if you do, then you're opening the door for us to start asking more questions about justifying what you're doing and why you're doing it. You should scrutinize yourself. So before you come, I'd go through it with a colleague, go through it with your mentor, and try and pick out what questions we might actually ask. And not necessarily we will review all the cases, but it might be asked of you if we're not happy with a particular case, that you resubmit a particular one, or more than one if we're not happy. So the outcomes: 2 attempts you get at passing the practical assessment. If you go for a second attempt, I'm afraid you have to fork out nearly £140. If you're successful in all 3 parts of the practical assessment, you will have already passed the theory, so you have passed the accreditation. You will be awarded a certificate on the day, and then you will be put on the accredited members list. If you're unsuccessful in any one of the 3 parts of the practical assessment, then unfortunately you've been unsuccessful at the first attempt, and we'll give you as much feedback as we can to help you come back for the second attempt and be successful. Okay, and if, for instance, you just fail the Viva aspect, then you will only need to come back and resit the Viva assessment. If you just fail the practical scanning and everything else was okay, you might not have to come back and do that again. Unfortunately, if you come back and you fail the second attempt, then you have to start the process right from the very beginning and collect a whole new logbook and a whole new lot of cases. That's very rare. So in summary, read the accreditation pack. It's very important to read it. It's got lots of information in. I've just picked out salient points, but there's lots more to it than that. And the more you read it, the more you'll feel comfortable with the process. Your mentor is very important, and you need to get someone who's experienced, and ideally someone who maybe has been through the process, or at least understands the process in detail. Use the resources that are provided in there. There's lots of references. There's lots of parts of the syllabus that you can look at, and you can go away and you can read yourself. And just avoid really simple common mistakes: incomplete logbooks, poor reports in the logbooks, reports that have been signed by other people and not yourself, reports that are not very accurate, or they don't contain all the data, your case mix isn't right, or you can open yourself up to questions about, should this case have fallen into this particular category? If you're still not fully competent or confident in yourself, then we'll pretty much find that out straight away when you come to the practical assessment and we watch you scan. So make sure you're at that level where you can actually come in and you can scan. And make sure your Viva cases are suitable. If there are any specific questions that either doesn't make sense in the accreditation pack, or there's something in there that you're not quite sure about, or you want a little bit more information, then you can contact the BSE, and there's an email contact for the accreditation team in the pack itself, and they are very good at getting back to you. And it should be enjoyable. It shouldn't be stressful. It's an enjoyable process. You're doing it for patient safety and for your own benefit. So you should come to the day and you should be at a competency level where you can actually enjoy it and discuss your cases with your colleagues. And I suppose the last question is, do I actually need to do this? Well, I'm obviously going to say yes. So I think you should do it because it benefits yourself and it benefits the patient. And that's me finished. Thank you for listening. There's just a link there to the stress accreditation page on the BSE website. Thanks.
Thanks, Martin. That was a very comprehensive guide on how to sail through a stress echo accreditation. And I can absolutely echo what Martin has said there. You know, you don't need to be an expert. You don't need to be working independently. You don't need to be, you know, writing your own reports. It's just, you know, it's a measure of competence. And I'd like to encourage everyone, you know, in stress echo, especially those who want to lead their own sessions, physiologists-led stress echo services, you know, go for it. Yeah, we're not there to try and catch you out. We're just trying to increase the pool of accredited stress echocardiographers. I think just a quick question, Martin, there's just one question. I think it's a quick one. For the acquisition assessment, do you assess baseline image acquisition and stress image acquisition?
Does this mean as part of the practical scanning?
I assume so, yes.
Yeah, so you should treat it as though it's a real world clinical situation. So you should walk into that room, and even before scanning, I will speak to the patient, talk to the patient about the risks, talk to the patient about if we're going to use contrast, what the risks of the contrast are, explain the procedure, explain why we're doing it, and then carry out how you would with a patient. And obviously with the patient, we will get baseline images. You don't have to do a full transthoracic echo, but you have to show that you are safe. So you need to exclude things that will preclude you to doing an exercise stress echo. So yes, you should do that.
Yeah, I think in our experience, just a quick look if there's any significant valve abnormalities like a severe AS or an outflow obstruction, any resting wall motion abnormality, we don't expect you to do it full transthoracic on the day.
I mean, it makes sense to do it anyway because you can practice getting the pictures when they start exercising. So it's a good tool to use just to reinforce that you know where the images are.